that perhaps azithromycin could modulate some of this inflammation in people with high levels. So how do we monitor lung function in our people? Well, we use spirometry, and probably a lot of people have had lung function done in the audience. And sometimes we look at lung volume by helium dilution. We look at respiratory muscle strength by measuring maximum inspiratory pressure and then maximum expiratory pressure. And really, it takes us about 15 minutes to do spirometry and our MIPS and our MEPS. And it really gives us a lot of information. So we found that even though, there are some potential problems with getting good pulmonary function tests, for the most part, we can get pretty good pulmonary function tests in most kids and adults. And what we do is, as you know, we have this mouthpiece, and it measures volume and flows here. We have the nose clips here, and a lot of times we'll have somebody help hold the head and help close the cheeks a little bit and make sure that the mouth seal is nice and tight so that we can measure all the volume coming out of the lungs. So sometimes there's some problems with coordination, and not everybody can do this, but I'd say probably 80 to 90% of our patients can do this pretty reliably and reproducibly. Sometimes the numbers that we get appear that the lungs are somewhat restrictive or small, but a lot of times it's because some of our people cannot blow out completely to residual volume, so it looks like their lungs are small, but they may not actually be small. And in those cases, we'll do lung volumes to kind of get an idea of what's exactly going on. So just to tell you, we've done about 96 individual children and adults. This was all done in outpatient spirometry. They were all medically stable at the time of testing. And then we had 18 individuals who underwent subsequent pulmonary function tests, on average about 2 years apart. So we wanted to look at how stable pulmonary function testing was in these particular individuals. So when we looked at the numbers, the average age was about 14. The body mass index was about 25, which isn't too bad. About 14% of our patients had gastric tubes for nutrition, and about 17% were on supplemental immunoglobulin. So when we actually looked at the numbers, on average, the forced vital capacity, so that's kind of a measurement of your lung capacity, and we do it by predicted values. So if you're a male, you have one predictive value, a female, and then we look at height and we look at age. And on average, the predicted forced vital capacity was about 56%, so that was about moderate restriction. And the FEV1 kind of followed suit at about 60%. The MIPS and MEPS on average were in the high 40s. Generally, the lower limit of normal is about 60, but this really isn't too bad. So it looks like for the most part, people were able to, breathe in, have fairly good strength breathing in and breathing out. And that's important for your cough, especially the MEP. So when we looked at some things that might be associated with lower lung function, and we found that the group that was on IV immunoglobulin tend to have, on whole, lower FEV1 and forced vital capacity than the group that was not on immunoglobulin. And that was the only thing that we really found. We didn't find any differences with people who had G tubes or not. So when we looked at age on the x-axis and percent predicted forced vital capacity, we started testing around age 6 or 7, and we found that there was a little bit of a U-shaped curve, which isn't too unexpected. And this is at about the 60th percentile. So about half were above the 60th percentile, about half were below the 60th percentile. And these are the kids that and the young adults that we'd like to follow the most closely, the ones with the lowest forced vital capacity, because they're clearly the ones that are at most risk if they get a secondary infection. So then we looked at the 18 individuals who had longitudinal studies, and we wanted to see whether or not lung function decreased significantly in this group. And these were people that we saw, and we kind of talked to them about the risk of lung infections and what they needed to do to try to keep healthy. And what we found was kind of nice. We found that, it was about 2 years between the first and the second visit. Their forced vital capacities, the actual volumes increased with age from 1.88 liters to 2 liters or so. And this is probably the most important thing, is the percent forced vital capacity, the predicteds, stayed the same. So that was really nice to see that there was no significant decline, at least in these 18 patients over a 2-year period. So we felt that that was a very good thing. So in summary of our results were that in cross-sectional analysis, we did find a significant association with lower percent forced vital capacity and people who are receiving supplemental IVIG. So this is a group that we want to watch, particularly close in terms of their lung function. And we found that no significant decline in FVC percent predicted over 2-year people in our 18 patients who underwent subsequent PFTs. We did have a few people who passed away, and generally they were the ones that did have lower forced vital capacities. This is just I just wanted to go over this really quickly. This was a group of intensivists at our institution, and they looked at anesthetic and perioperative risk, and they looked at 21 patients who underwent 34 procedures, and basically they found that there were no major complications, no unplanned admissions, and no mortality in the patients that underwent procedures at Johns Hopkins. So we were very happy to see that. These are specialists. A lot of these patients had a lot of complications and morbidities, but they did very well with these planned procedures. In terms of the people who were critically ill, they looked at 7 patients. They did find if you were admitted to the intensive care unit, the most common problem was respiratory distress. And on average, anytime you go into the intensive care unit with severe respiratory distress, like in cystic fibrosis, it's about a 50% mortality, and we found about the same with our AT patients. So just some general guidelines to consider. We think it's very important to recognize chronic infections and to treat infections aggressively. Pulmonary symptoms in the absence of infection may indicate interstitial lung disease, and you would treat that different than you would with an infection. So these may be people that we would treat with courses of steroids. We find that if you optimize nutrition and minimize risk of aspiration, overall the people tend to do better. And then in people who do have recurrent infections and decreased pulmonary reserve, I would consider aggressive pulmonary clearance techniques, so considering chest physiotherapy, perhaps the therapy vest, and in some people who are really weak and have a lot of secretion, maybe the cough assist. We believe to optimize outcomes, any surgeries or major medical treatments should be done at tertiary care centers that can address the unique needs of somebody with AT. And we really feel from following our patients longitudinally that even patients with lower pulmonary function tests can live longer if efforts are made to really limit ongoing lung injury and optimize their existing lung function. Just to remind you that decreased pulmonary reserve is often recognized late, so we really think that these children should start having pulmonary function tests as early as possible. We start at age 6 or age 7, so that we really kind of catch when they start sort of dipping a little bit. They do have they have decreased pulmonary reserve and a limited ability to cope with major illnesses, malignancies, and surgery. So we need to really be very careful anytime, a surgery or if they have to go through chemo. We want everybody to monitor lung function, and we realize that a multidisciplinary approach is needed. So we work with the neurologists, we work with the immunologists. I think everybody needs to talk to each other, and I think everybody's in agreement with that. This is just from our review article, and I won't go into this, but basically we think of the lung disease, we break it into three kind of categories. It's a little bit simplistic, but this may be helpful for your doctors or for you, just to type things to look for. We know that the children who have problems with swallowing and have more neuromuscular discoordination may present with trouble clearing their secretions, a weak cough, congestion, poor weight gain. And then these are the things that we want to try to avoid and monitor weight gain, try to keep the calories high, and maybe start some chest clearance techniques. Other children who may present with interstitial lung disease, often the symptoms are dry cough, breathing fast, no response to antibiotics, fatigue with activity, and then these are some of our treatment options down here. And then finally, the people who have recurrent infections, we like to be aggressive, either oral or IV antibiotics, chest clearance techniques, make sure that you don't need immunoglobulin replacement if indicated, and then sometimes we will start prophylactic antibiotics such as azithromycin at least 3 days a week. We want to treat these infections aggressively and make sure the immunizations are up to date. So that's really all I wanted to say. I think, this is a really important area that needs to be addressed, and it's been a real pleasure working at the AT clinic and working with my colleagues, Howard Letterman, Maureen Leftengrave, Tom Crawford, and Jenny Wright. And we get a little bit of support from the AT Children's Project, and we really get a lot of support from our children and adults who participate in our studies. Thank you.